Hi, my name is Lakshmi Chawla, and I am a professor of medicine at the Department of Medicine and University of California, San Diego. And welcome to my talk on acute kidney disease, renal recovery, and chronic kidney disease. So, this talk really begins with a recent consensus statement that was published in Nature Reviews that was convened by the Acute Disease Quality Initiative work group. And what we really sought to do in this meeting is talk about two new concepts. One is acute kidney disease and the consequent renal recovery and the definitions therein. So, when we think about AKI and CKD, I think we all recognize that age, certain race or ethnic groups, genetic factors, hypertension, diabetes, and other um, risk factors clearly predisposed towards both chronic kidney disease and acute kidney injury. I think it's become abundantly clear over the past decade that there's a clear interaction between these two syndromes, much of which is driven by these disease modifiers of severity, the pre-existing stage of chronic kidney disease, duration, episodes, and other potential renal defects like proteinuria that can impact this. And this interaction has been very strongly linked to important outcomes like major adverse cardiovascular events, end-stage renal disease, death, and also a really poor quality of life because these all interact with one another. So, just to sort of spend some time on this, there are large series of data now that show your KDIGO stage during your acute episode drives a lot of the risk. And much of this, we believe, is due to loss of nephron mass and injury to kidney architecture that then causes downstream knock-on effects. I think it's pretty clear that your baseline stage of chronic kidney disease matters, but I think that the big issue that we're beginning to look at much more carefully now is your duration of acute kidney injury. And even though I mentioned it before, recall that duration isn't just necessarily about the acute episode, but it also impacts this notion of renal recovery and the idea of when is the kidney actually fully recovered. And we'll talk about this in some of the slides coming up. But this is a very important concept. And I think that the first thing that we tried to tackle was this notion of persistent acute kidney injury. I think we all recognize that patients have an episode of what's transient AKI, the serum creatinine goes up and then comes back down. And in order for us to have a series of definitions that make sense that all of us can use together so we can study this phenomenon, we sought to define this. So in the first consensus statement, we really arbitrarily selected 48 hours of a continuance of increase in serum creatinine or diminishment of urine output as the definition of persistent acute kidney injury. Now, I said it's arbitrary, and it largely is, but recall that there are some data that suggest that this is a critical time point, and clinically, if you get worse one day and get better the next, it's sort of reasonable to say that this is a transient event. We also selected this based on some preliminary data suggesting that 48 hours and the completion of 48 hours may be a good selection time point. But that said, this was not a high level of evidence recommendation. This is a consensus statement for which we hope to build data and confirm that this recommendation is the correct cutoff for persistence. The second consensus statement, in order to have some harmonization of this, is that really what's the difference between AKI that gets a little bit better and then you get a second episode? And in order to have some basic definitions to separate episode A from episode B, we also sought to do this with a 48-hour difference. And I think that the most important consensus statement that really leads to the rest of this talk is what is acute kidney disease. And I'll spend some time on this in the following slides, but this is a term that had been proposed by the first KDIGO group, but really did not have a clear definition. And in this work group, we really sought to further clarify this. Now, if you think about the classic KDIGO definition, we have this very clear period of time, which is acute kidney injury, change in serum creatinine that occurs over 7 days. And I think that this was an extremely useful definition and has been verified now in a series of over 500,000, perhaps even 1 million patients now have been reported. But we also know that the definition of chronic kidney disease begins at 90 days. And so this sort of leaves this gap in between patients who may not have fully recovered from acute kidney injury, but by definition have not had the kidney disease for 90 days. And this had been called by the initial KDIGA group as AKD. And I think that that's the appropriate term, but there wasn't clear definitions on how we defined and or stage this period of time. And this is really an attempt to put some clear classification structure, because if you cannot define it, and if we cannot all agree as a group what we're going to call things, it becomes very hard to study them and then compare apples to apples. So the definition of AKD and recovery from AKD is based on the fact that AKI now is technically within the first 7 days, and this period of time between 7 and 90 days is what we're now describing as acute kidney disease. And within acute kidney disease, there are multiple things that can happen to an individual. They can, of course, pass away, they can recover, they can have a recurrence of AKI, and they can have progressive AKD. And these are all sort of subtypes or forms of potential recovery that can exist. And then we reiterated the initial construct that once you go beyond 90 days, if the kidney disease is ongoing, you now then cross over into the classic and well codified chronic kidney disease strata. And I think that this is important to make sure we harmonize with the rest of the community to make sure our definitions match. So what we've done, and I'll show you this on the next slide, is we've attempted to harmonize the AKI and AKD definitions so that they make sense and it's not a whole new series of things people have to worry about. So I want you to direct your focus here. And essentially, in acute kidney disease, the staging system is effectively identical. Now, the one thing which has come out of this is oliguria, but from a serum creatinine standpoint, what you fundamentally see is the exact same change of ratio of serum creatinine over baseline in stage 1, stage 2, and stage 3. And the reason why oliguria comes out of this is because the time period is so much more extended, and from the clinical clear observation that persistent oliguria over an extended period of time almost always results in an embarrassment of serum creatinine and a rising creatinine. And this then allows for a little more simplistic approach without the need for hourly urine output data. Now, we also recognize now that patients who do not recover fully below this 1.5 range, this is still not necessarily full recovery. And I'll show you some data of why we believe this to be the case. And so within stage 0, and I know this may seem a bit confusing, we still have a stage A, B, and C, which is essentially subclinical AKD. So basically, if you return to less than 1.5 of your serum creatinine, you are no longer stage 1. So I think that's fair. You're now essentially a stage 0, but this still may represent a form of subclinical AKI. And we allowed ourselves to describe them with these criterion A, B, and C. So to really put a magnifying glass on this, what you see here is the harmonization of the KDIGO stage 3, stage 2, and stage 1 that match very well. And I think we had made allowances in the recent literature for patients who had biomarker positive AKI, which is subacute AKI. And this then very neatly moves over into the same general vicinity of stage 0 subacute AKD, just so we're all using the same language. And I think it's important to recognize that much of these insights really came from some seminal work that John Kellum's group did that we all worked on together that looked at the type and manner in which someone can recover after acute kidney injury. And so this is a data set that was run through the University of Pittsburgh. And what they demonstrated in the data set is that there are all sorts of various trajectories for patients with acute kidney injury. Some people have sort of classic AKI, and then they just progressively get worse, worse, and worse, and they progress up here to a stage 2 or 3 type of trajectory. Now, technically, because they remained below stage 1 before 7 days, this would have been called subacute AKI. But now that we have an ability to describe the disease after day 7, this would be a patient that was stage 2, perhaps 3 of AKD. And so you recognize that there is this temporal change. And this might be a patient who's receiving, long-term aminoglycoside therapy for endocarditis, for an example. Then you have sort of this much more typical severe acute kidney injury that we may associate with shock or trauma or hypotension or severe infection, where there's this, initial very severe increase in serum creatinine and loss of GFR that then begins to recover over time. And so, this patient would have been purely codified as a stage 3 AKI. But you can see as they recover over time, they then move into a different AKD phase. And, we can call this, a second type of definition of AKD. And then you have another patient who has a similar severe sort of embarrassment, but a more rapid initial recovery with a tapering off. And this is another form of AKD, but these are really two very different trajectories of recovery. And then you sort of have this stuttering type of AKD where you have the initial insult with this period of potential recovery and a worsening, and based on the criterion we've set out, that this was 48 hours, this would represent a second event. And you might imagine a patient who is in shock, who has an initial severe AKI stage 2, begins to recover and then perhaps gets an episode of interstitial nephritis due to an antibiotic and has a second hit that then sort of begins to resolve. And then there's these patients who have this very abrupt loss of GFR that rapidly recovers, and because this occurs in a very short period of time, this would fit into the criteria of rapid reversal. And so, all these patients that are shown here, except for the one in orange, all have severe AKI stage 2, stage 3, but you can see how the recovery phases are really quite variable. And what was shown in John's work that we all worked on together is that that type of recovery really matters and tracks to outcomes. And so within this grouping of subacute AKD, we have very carefully specified 3 subcriteria, A, B, and C. So C are patients whose serum creatinine has not returned to baseline but remains below this 1.5 threshold. So if a patient has a baseline creatinine of 1.0 and they recovered to 1.4, they wouldn't qualify, obviously, for stage 1, but they're not back to normal, and so this person would be essentially a stage C. Now, you may have a group of patients who recover their serum creatinine but have ongoing or an obvious severe biomarker level of injury, and either a loss of renal reserve or ongoing or severe biomarker injury would be codified a B. And really, if you have neither B or C, that would be a place where you'd allow to come back to what would be deemed to be, at least from a serum creatinine standpoint, no evidence of ongoing or injury, which would be stage A. And, there are a whole host of patients who, have ongoing disease, and then if they cross the 90-day threshold, they would have CKD. Now, the reason why this is important is these are data from Nish Panda's group, and what Nish's group do is they have broad access to the province of Canada's Alberta healthcare system, which is a very large data set that has very high fidelity data, a high level of granularity. And what it allowed them to do is look at a very large cohort of patients who had acute kidney injury and then look at their hospitalizations and map their recovery. And what they found, I think, which is very important, this is your reference group up here, and these are for patients who have ongoing RRT or severe CKD events, is that if you are above this 50%, so this would essentially be patients who remain with a serum creatinine above 50% of baseline, you can see they have an ongoing hazard CKD for ongoing severe events. Now, if they get to within 50%, the hazard ratio drops quite dramatically, and it is not nearly as bad as having a larger increase in serum creatinine, but you can still see that they do not return to zero risk. The hazard ratios and the confidence intervals do not cross one. And it's only when you get to here, within around 15 to 25% of your baseline, that you begin to show that the ongoing risk is no longer there. And what this suggests then is that some level of AKD into CKD, getting back fully to somewhere between, I think, 5 and 25% is the point where the ongoing risk from the initial event appears to diminish. Well, this is really important because these patients are not currently captured in the AKI system. And within AKD, these patients who still have the increase in creatinine before 90 days will be considered patients with a stage 0C type of staging. And this stage C is clearly associated with increasing risk. And if you look at this paper in detail, it's also the risk for increased mortality and increased risk for severe renal events related to ESRD and CKD. And so Claudio Ronco, John Keller, and Michael Hassa have made it very clear in a editorial viewpoint that subclinical AKI is still AKI. And where I think at least some of this data come from, and this has now been demonstrated with a whole host of biomarkers. This just happens to be a multi-center pooled analysis of patients with NGAL. And what you see here very clearly in group 1, these are patients who are serum creatinine negative and NGAL negative. This is their baseline series of events, right? So what you see here is the incidence of events here, about 5%, whether it's in-hospital mortality or renal replacement therapy. Now, if your NGAL is elevated, but your serum creatinine goes up, so this is a biomarker positive or subclinical AKI, you can see the event rate goes up very dramatically. If you have the converse scenario, which are patients whose biomarker are not very elevated, but the serum creatinine does meet criteria, they have increased events compared to baseline. But if you have both, you have more severe events in every category, which sort of makes sense. And what this is suggested, and given the large numbers of this analysis, and this has now been demonstrated with Nephrocheck, which is a combination of TIMP2 and insulin growth factor binding protein 7, is that if you have biomarker positive injury, this is something which accrues risk. And subclinical AKI almost certainly causes a loss of nephron mass, which appears to have knock-on effects for risk. And so when we think about these subgroups, we are really concerned and talking about these ongoing biomarker loss of renal reserve groups, which is important. And so, you could have patients who have both. They could have patients their creatinine is not back to normal and they had ongoing or severe biomarker injury. And, those folks would very much look like the folks over here, right? They had both serum creatinine and ongoing or serum creatinine elevation in addition to their biomarker. And you could have just patients who had a biomarker increase, appear to lose renal reserve, and then renal reserve puts them at further risk moving in the future. And if you have neither of these two that are measurable, we then denote them to basically be no evidence of injury. And so now if you look at the entire sort of progression from AKI, which is in this first 7-day period, on to 7 to 90 days, which is AKD and CKD, you have this sort of linear assessment of AKI to AKD to CKD. And, on a piece of paper, this is very attractive. It makes a lot of sense. It maps to a lot of patients in a very reasonable fashion. But we also know that this is really probably a little too simplistic. I think it makes for a very thoughtful way to think about what AKD is. But really, we know that AKI and chronic kidney disease interact with one another. And at some point after your initial 7-day period, is it really right to call it AKI versus CKD? I think the answer is we accept that we don't know what the precise label is, and that AKD is a reasonable place to talk about what it might be, but it almost certainly has components of both. And the folks who go on to progressive chronic kidney disease clearly have different types of injury, knock-on effects, and perhaps different genomics and metabolomics than those who recover. And what we recommended is a sort of, stratified approach, which is really quite simplistic, which is that we want to layer on what we do. So if you have stage 1 AKD, then what we really want to do is be careful, treat your kidneys gently, making sure patients know that their kidneys may have taken an injury. We want to make sure their medications are correct, they're dosed properly, and that these patients need some real education, and the physicians need to know that they had a previous injury and that nephrotoxin avoidance may be very thoughtful. I think that it cannot be understated that documentation of minor AKI or AKD events is really important. And if the stage goes up, I think it's very appropriate to have more follow-up. And I think very importantly, for any patient who achieves stage 3, either AKI or AKD, to the degree that it can be logistically done, a nephrology referral, in my view, is mandatory. And so, Louis Forney and some of the group of our colleagues in Europe have written a review article trying to integrate some of these components of AKD, renal recovery, and how we think about the management of renal recovery after acute kidney injury. And, they show very beautifully, I think, in this figure, something which is important, which is there is this group of patients who get AKI and they fully recover, and this works out very well. Ideally, we want this. But there's a host of patients who have ongoing maladaptive effects or ongoing injury, and this is typically impacted by the risk factors that we previously discussed, whether you're diabetic, metabolic syndrome, your severity and duration of AKI. But you begin to start experiencing mitochondrial defects, decreased capillary density, the beginnings of a pro-fibrotic milieu, perhaps some inflammation. And this type of trajectory, basically, in my mind, we can think of it as pre-CKD. So even though you don't have the drop in creatinine that may qualify you for that designation, in the kidney, it's looking like that even before you have the loss of GFR. And what's so important about this is this may be a real opportunity to intervene because these patients are largely recovered, but they haven't yet progressed to chronic kidney disease. And so this is the staging, again, linear, but really separating out your group of patients with early recovery from late recovery. And then, of course, those patients who do not sort of get to a point of recovery, then unfortunately can move on into CKD, which is obviously something we're working very hard to prevent, given the very important public health considerations, knock-on effects, and risk factors that occur with chronic kidney disease. And so this is their proposal, which I think is reasonable. I think perhaps it's a little conservative, but just to take you through it, patients who have AKI, and I would argue this should also be AKD, stage 2 or 3 during a hospital admission. I think it's critically important that there be an assessment at discharge. Do they have advanced renal dysfunction? And if they do, clearly they should go for a nephrology referral. I think that this follow-up that they're recommending 3 months after discharge may be late. I think that we have to be a little more thoughtful about these patients, and patients who have had a severe event and are not fully recovered, I think ought to be tracking a little more thoughtfully, at least with a primary care physician. Does not necessarily need to be a nephrologist, but with some guidance, what to look for, and to make sure they're not spiraling out of control. I think that, although many of these people are dear friends of mine, I would largely disagree with this time point. I certainly agree if the renal function is stable, they can get regular follow-up. But I think reviewing at 1 year is just too late. I think that the opportunity to intervene, to make sure they don't get nephrotoxins, to make sure their blood pressure is under control, to make sure the other types of things that may impact progression of chronic kidney disease or evolution of AKI to chronic kidney disease really need a little bit more surveillance. Now, to be fair, this has not been rigorously tested, and I think when you're writing a review article with big impact that may affect your healthcare systems, this is certainly reasonable, but it's my bias that we need to do this more frequently. And so, in summary, I wanted to take you through some really key notions that are moving forward. And the first is that we have some clear and thoughtful definitions for persistent AKI, and the definitions are as proposed. And I would like to see the people in the room here listening to this talk understand that we want to use these definitions, but we want other people to verify and validate these data. We have extended the spectrum, so we don't have this hard stop anymore with AKI at 7 days. It moves on. I think we have much more effectively captured the nuance and possibility that exists between 7 and 90 days where the CKD definition takes over. And in my view, this is an advance forward for nomenclature and standardization and harmonization. I think one of the key take-home messages is that it's not just good enough that your kidneys recover. You really want to have them recover more rapidly and more promptly and get back to baseline faster. And so that to me is an opportunity where if we can utilize medications or therapeutics or other types of interventions to hasten the recovery, I think that could be a real piece of advantage we could bring forward. And I think that lastly, if nothing else, we must follow up these patients after acute kidney injury, especially those who have severe AKI. The higher the stage, and any patient who has AKI requiring dialysis, I think it's absolutely mandatory that they be carefully looked after and they see at least a primary care doctor with some direction as to what to look for. So thank you very much for your attention. And again, apologies for not being able to be there in person. This has been a trip I very much looked forward to, and I'd be delighted to answer any questions. Thank you.